Hello, hello.
Please.
Good morning, respected panelists. Myself, Dr. Snehal Rajgire, is going to present the case report on Alport syndrome. Huh? कौन सी बताना? A 20-year-old male presented by his parents to the OPD with the chief complaints of both eyes diminution of vision, which was gradual, painless, progressive with intermittent headache, vomiting since last 3 months, no redness or ocular pain. The parents also notices impaired hearing and generalized weakness. On further evaluation, he had an episode of hematuria. There was no history of dialysis. Family members were not evaluated for the same. They were not giving any history. Refraction of the both eyes compound myopic astigmatism, regular astigmatism, and keratometry were within the normal limit. On examination, he was conscious oriented, IOP were normal in both eyes. Anterior segment reveals the bilateral clear cornea with the conical protrusion of clear lens, that is anterior lenticonus. Distant direct ophthalmoscopy revealed the oil droplet appearance. On OCT, there was normal foveal contour, and he was found to have the high blood pressure, that is 160 by 110 mmHg. These were the investigation in which the patient showed anemia, serum creat was raised 2.7, and urine analysis shows 35 to 40 RBCs. These were the anterior segment imaging, which reveals the both eyes clear lens protrusion, that is anterior lenticonus. OCT macula were normal both eyes. These were the pentacam imaging. So my provisional diagnosis is Alport syndrome. A short info about the Alport is the Dr. Cecil Alport was the first to describe Alport in 1927. It is a progressive familial kidney disease leading to the basement membrane disorder, which is a type 4 collagen. So this type 4 collagen is most important basement membrane found in the cochlea, glomerulus, descent membrane, Bowman's membrane of cornea, anterior capsule of the lens, ILM and the Bruch membrane of the retina. So all these are affected in the Alports. Main gene affecting is the call4A5 gene, which is an X-linked, most commonly seen in the males, and all the females are the carriers. Alpha 1, total 3 genes are affected, that is 3, 4, 5, which are all present in the Bowman's membrane of the eyes, basement membrane of the eyes, ears, and the GBM. In electron microscopy, we will see the alternate areas of thickening and thinning of the GBM and the splitting of the lamina densa, which will give the basket weaving pattern. 3 ocular manifestations are seen, that is cornea, lens, and retina is affected. In cornea, we will see the PPD, posterior polymorphous dystrophy. In retina, we will see the giant macular hole, which is normal, which is more than the normal. Then dot and flex retinopathy and temporal thinning of the retina. In lens, we will see anterior capsular cataract and anterior lenticonus, which will give the oil droplet appearance. So anterior lenticonus is an anterior lens protrusion through the thinnest capsular area. Cataract can develop as a result of the process of healing of the spontaneous capsular rupture, which appears due to the absence of the call4A5 gene. Oil droplet is a pathognomic sign which can be seen on slit lamp or IDO or retinoscopy. The myopic shift and abnormal lens shape due to the anterior lenticonus actually lead to the blurry vision. Bilateral sensorineural hearing loss usually appears by the age of 10, which goes parallel to the symptoms, renal symptoms, which are more frequent in the male. We will get the triad of kidney disorder, anterior lenticonus, and sensorineural hearing loss in Alport. So this is a short about Alport. So finally coming to our discussion. So our patient had all these 3 symptoms, so we suspect Alport syndrome. In the view of these classical signs, hearing aid was advised for hearing impairment along with auditory and ENT opinion, nephrologist opinion for kidney biopsy. Decision were taken for clear lens extraction with IOL implantation, but the patient was lost to follow-up. So the conclusion, we report a rare case of Alport syndrome. Detailed evaluation and early treatment of these variants are required to improve the quality of life. Early diagnosis is important in order to provide the appropriate multidisciplinary treatment by nephrologist, ENT, and ophthalmologist team. Early intervention can provide a better hearing, leaner, and visual prognosis can provide a better quality of life. Thank you. Yes. Thank you, ma'am. Vision, 3 by 60 and 2 by 60 almost. Yeah, yeah, cataract and high myopic astigmatism, both eyes, -8. Yeah. Yes, because of anterior lentigonus, that's why there was. Yes, yes.
And what was the cause of renal failure in this patient? Renal failure?
No, patient doesn't have renal failure.
Because the urea is high, creatinine is high, the patient is hypertensive.
Yes, yes, yes.
Was there any hypertensive changes in the retina because of
No, no, no. There was no changes in retina. Retina was totally normal.
the macular bone is there,
N-
na?
n-
That's one of the you're talking about the macular bone.
Yes, sir. In my presentation, there was nothing in retina. In generalized, I told. Yeah, in generalized, I told that so many findings are there, but R was very rare. Like we don't have any OCT was normal. Usually, temporal thinning of ILM is present. My OCT was normal. Then my fundus were normal. Usually, dot and flex retinopathy is the first early sign, but that was also normal. So actually, we were waiting for kidney biopsy and everything, but a patient didn't come back. So I took it as a e-poster because I don't have much to present in my case. Yeah. Yes, yes. I didn't have anything, but the three symptoms that renal, that hematuria, hearing impairment, and anterior lentigonus, these were the classical for Alports. Yeah, we don't get this tried in anything else. We get in Alports.
Do you expect any difficulties during your cataract extraction?
Yes, ma'am. We will get two difficulties while making the CCC, capsulorhexis, and while hydrodissection. For hydrodissection, we have to be very gentle because there may be associated posterior lentigonus too, so associated with posterior polar cataract. So we might get the posterior capsular rupture. And while CCC, it tends to run out in the periphery. So we tend to do not start in the center. This is the tip. We have to start from the beyond the cone and try to involve the cone in that flap so it doesn't go out, and we have to maintain the chamber with the visco so that it doesn't go out in the periphery.
I think very nice presentation.
Thank you, sir. Thank you. Thank
We
you.
have learnt a lot from you today.
Thank you, sir. Thank you.
Who's the next speaker? Is Subia here? Dr. Subia here?
Good morning, everyone. And my topic is comparison in conventional versus capsulotomy with anterior vitrectomy in congenital cataract. And in the introduction, phacoemulsification is a well-established surgical technique for cataract removal that has revolutionized cataract surgery with its minimally invasive approach and rapid recovery time. In congenital cataract cases, the cataract is present from birth or develops early in the life, and the complexity of the surgery increases due to the altered anatomical structure and the potential for associated conditions like amblyopia and strabismus. The conventional approach may be effective for most cataract cases. However, congenital cataract often present additional changes. Recent advancements in surgical technique have introduced methods such as anterior and posterior capsulotomy combined with anterior vitrectomy. Anterior capsulotomy involves creating an opening in front part of the lens capsule to facilitate the lens extraction. In the posterior capsulotomy involves making an incision in the back part of the lens capsule to address potential posterior capsule opacification. Anterior vitrectomy, which involves the removal of the vitreous body, is employed to manage any complication or to create a clearer surgical field when the vitreous body is involved. The comparative study of these approaches aims to evaluate the efficacy, safety, and visual outcome of conventional phacoemulsification versus the combined technique of anterior and posterior capsulotomy with anterior vitrectomy. In this, the study seeks to determine whether the added complexity of the combined approach offers significant advantages over the conventional method in terms of visual acuity, surgical complication, and overall patient's recovery. And the aims and objective to evaluate comparison, complication, and visual outcome of the lensectomy and with anterior vitrectomy and conventional method in the surgical management of congenital cataract. In the material and method, the inclusion criteria are children with less than 12 years of age, children with congenital cataract without posterior segment involvement, children of both consanguineous and non-consanguineous parents, and in the exclusion criteria are children with age more than 12 years, children with congenital cataract with posterior segment involvement. In the result, in the age and sex distribution, most commonly age were involved 5 to 8 years, and there was male predominance. In the laterality of the cases, 70% cases were the bilateral, and 30% cases were unilateral. And in the type of incidence of the associated ocular congenital anomalies, most commonly was present nystagmus followed by the strabismus. And the type of cataract, total cataract was present in the 7 cases. Membranous cataract was present in 1 case, and incomplete cataract was the 25 cases. In the type of operation, in conventional method, 7 cases were done with the decision, and in 6 cases with decision and aspiration. And lancectomy and vitrectomy, limbal approach was done in the 16 cases, and pars plana approach in 4 cases. In the final visual acuity, 6 by 18 or better, most of the cases with their better visual acuity, and the relationship between age and the operational visual field, final visual vision obtained, age more than 4 years have better visual outcome. In the relationship between type of operation and final visual outcome, lancectomy and vitrectomy has a better visual outcome comparison to conventional method. And the number of complication, most common complication was posterior capsule opacification. In the conclusion, though no sex predilection has been reported in the congenital cataract, in this male preponderance was observed with highest incidence is age group of 4 to 8 years. Being a comparative study, 39.3% cases treated by conventional method and 60.7% cases managed by lancectomy and anterior vitrectomy. The visual acuity was compared amongst the patient managed by conventional method. 37.5% had good vision, 12.5% had fair vision, and 50% cases had poor vision. In the lancectomy and anterior vitrectomy treated groups, 61.1% cases had good vision, 22.2% had fair vision, and only 16.7% had poor vision. And the total incidence of complication encountered was 66.6% in 16 out of 33 eyes, in which conventionally treated group showed in the incidence of 32.4% as compared to the 4.4% in lancectomy and anterior vitrectomy treated group. Thank you.
Yeah, very elaborative presentation. Definitely the incidence of PCO is more with the congenital cataracts. That's why we need the anterior vitrectomy also with. So, any suggestions?
I think the key point of your presentation was all the age group was beyond 4 years. So you did not think of doing capsulotomy and anterior vitrectomy. Did you do it with the capsulotomy?
Ma'am,
posterior capsulotomy?
Yes, ma'am, posterior capsulotomy.
And anterior vitrectomy through the anterior route or the pars plana route, as you said.
Limbal route.
Okay. So when you're talking about PCO occurring despite this, so you're talking about PCO in general, or talking about cases where you had done the, sort of PPC and still you were having PCO in the surrounding?
PCO
in general.
In all cases, yes.
So you have not, done a group analysis like those we did the posterior capsulotomy and how many of them actually had this visual problem because of PCO.
Yeah.
That you didn't. Okay. Otherwise, the usual practice actually, it's a usual clinical practice to be doing this, definitely. So up to what age group did you actually do the posterior capsulotomy?
Ma'am, in my cases, all were less than 12-year age group.
Less than 12. So you went for posterior capsulotomy, randomized, and went for posterior capsulotomy in all cases. Okay. Fine.
Thank you.
Anyone here? So I think you are left with the presentation only.
Okay, I have got another presentation in, Studio One, okay? So has my thing, I have given it to somebody to load it from the preview. Has it come? देख लीजिए। नहीं, preview room में load करेंगे तो यहाँ नहीं आएगा, direct लाना है। अगर उस वाले में hall में गया होगा, उस hall में नहीं गया है, इसी में लाना है। हाँ, बस इसी टाइम में। मैं last speaker हूँ, 6 नंबर पे। A rather very short presentation on target emmetropia, ocular surface stabilization and achieving refractive surface for a new presbyopia correcting intraocular lens. Good morning, everybody. And as you know, I'm the panelist and the last speaker for the session. So, of course, no financial interest has been accepted for publication in an esteemed journal. So, nowadays, younger patients are having cataract and becoming more demanding regarding, spectacle-free independence and visual satisfaction. And we have to cater to such patients by our careful selection. So refractive success is limited by factors that limit actually the accurate IOL power calculation, the tendency for photic symptoms, or the cost. And these factors summarized as red flags, and we present an approach to a patient who, despite several red flags, achieved refractive success. So this was a 53-year-old female with complaints of frequent change of glasses and diminution of vision, who was wearing plus-part spectacles all her life and bifocal glasses for the past decade. She had been using heavy eye makeup since her teenage with occasional contact lenses, a fashion designer by profession. The ocular examination showed a UCV of 660, 636, which was corrected to 66 with a plus 2.25 and an N6 by an R of plus 2. The other positive findings were heavy deposits of coal and glitter on the agnetha with meibomian gland disease grade 2. And there was also moderate dry eye disease with a decreased T by to 5 to 10 seconds. And the pupillary size was 4.75 and 5 respectively. The pentacom chord mu was 0.6 and 0.4 in all others types of chords. All other findings were normal. So she was advised sequential 2.2 phacoemulsification, but she demanded complete spectacle independence, and her occupation wanted fine tailoring work to be possible, and she was also so demanding and looked like a type A personality. So we tried to defer her, implantations till we gave her spectacles for the time being and treated her meibomyitis and dry eye with warm compressors, lid massage, cleaning, tablets, doxycycline, drops of sodium hyaluronate, cyclosporin and azithromycin, and told her to avoid eye cosmetics. However, she had poor compliance and needed 6 months for treatment, during which her pentacam values and IOL master 700 values changed, and she was monitored on the basis of ocular surface debris, consistency and expressibility of meibum, and patient-reported compliance to therapy. During this, her cornea profile became regularized, her aberration values improved, the curvature regularized, the corneal part symmetrized, and the sphericity became more favorable. And then the comprehensive visual needs assessment questionnaire by J&J was used to determine the proportion of her tasks and preference for near and intermediate vision. So based on this, a hybrid EDOF plus trifocal IOL design was preferred, and because the patient's affordability limited the choices to Indian lenses, so using a Barrett's Universal 2 formula with a plus 22 diopter lens, uncomplicated phacoemulsification was sequentially done in her 2 eyes. And at the end of the first POD, she had a 6X and 6 vision, and a visual function questionnaire, 3 out of 7, showed no symptoms and no acceptance. So last follow-up, she had no symptoms, the lenses were well-centered, without PCO. Then she had reduced her indiscriminate use of eye cosmetics and was very happy about the spectacal independence, and had to be maintained, of course, on sodium hyaluronate eye drops all her life. But the learning points are that bilateral, this multifocal IOLs are better, and as of that, and EDOF lenses have got better contrast sensitivity, a decreased spectacle dependence for all distances, and lesser visual disturbances compared to bifocals. And then, therefore, literature really lacks this, reviews of our AdTech Extend IOL, the Indian multifocal plus EDOF. So in a patient who was first unsuitable, we implanted this. And of course, the IOL Master and Shimflug helped us in this case. But then after ocular surface optimization and MGD treatment, we were able to achieve this refractive surface. This is one of the few case reports using the J&J Vision questionnaire for visual needs assessment, as well as the VFQ 3 out of 7 questionnaire for patient-reported outcome measures. Of course, we have limitations of not being able to measure the contrast sensitivity, the wavefront aberrometry, or the post-operative photic phenomena in varying light conditions and stimuli. However, she has reported no symptoms. The conclusion is that assessment of needs and stabilization of the ocular surface, meticulous corneal assessment, and IOL power calculation are mandatory for refractive surface. And properly performed, the advantage of spectacle independence can be offered to all the patients who are otherwise deemed unsuitable for presbyopia correcting IOLs. Thank you for your kind attention. These are my references. Yes, right. But yes, in a type A and with MGD and with, yes. I think I had a very good person to actually calculate the part, and we actually waited for the ocular surface to stabilize. And then when we were fully confident that, okay, now her power calculation is coming as consistent, and then we dared to implant this lens. Actually, we dared to, and we got away with it.
But adding the EDOF to trifocal, does it add to something else? Because already you're giving trifocal, adding EDOF, does it offer any advantage to the patient?
I think because this was primarily because, I think AdTech Extend has got this claim, and rightly so, of being able to avoid the photic phenomena as far as things are concerned. And one other thing which prompted me to implant this lens was that she was not a person who used to drive at night. So we said that, okay, let us go with it.
Nice presentation. Thank you.
Thank you. So do we have any other presenters coming in, please? This is the last call, I believe. Okay. So I think we can call it a day, sir? Yes, thank you. Thank you for your presence, presenters. Yes, please do.